Greetings again. This is Dr. Bill Wyatt with the American Orthodontic Society, and I want to talk to you a little bit about temporomandibular joint problems. You probably have gotten more of this than you really want, but it's something that we really need to understand to be able to help patients. Now, you think that only certain people get temporomandibular joint problems, and that's not a fact. I mean, young people get them. They get hit or bruised or shoved in the mouth with something, or the chin, and shoves their condyle back into this retrodiscal tissue, and just irritates the dickens out of it. It gets inflamed and swells up, and now it hurts all the time. And that's kind of what's happened, I think, in this particular patient that I'm going to try to go through with you today. Excuse me. This is a beautiful young lady, and she's come down with a temporomandibular joint problem, plus she's Class 2, Division 2. In other words, that's, let me show you her teeth and you'll understand that. She's smiled. She's got, some people like Class 2, Division 2, think they're beautiful, and she is a beautiful young lady. But the teeth are not setting like they should be. One thing, the upper teeth come in on a child and they're by themselves, and they come out here, and a lot of times the child is swallowing with a tight lip structure, and they'll tend to bend the teeth back this way, and now the laterals will come out beside them, and a lot of times they'll come down as these are, just a little bit off to the side. They're not pinching these a great deal, but the centrals are this much too far down below the lateral teeth. Now, in addition to that, the whole angle of the tooth, you'll look at them in a few minutes and you see this is a Class 2 jaw. The jaw is not out far enough, and it should come out like this. And at this point, the jaw wants to come forward, but the teeth will not let it come out like that, the way that they close to. Let me just see if we can go to another picture. You can see the upper anterior teeth are over the lower anterior teeth, and they come up and fit underneath here, and there's some wear facets where they have chewed against the enamel of the upper teeth. And so this jaw wants to go in a forward direction, but it can't go that way. You can tell by letting somebody just relax their mouth and just open and close and don't touch your teeth together, and normally your jaw will go where it wants to go. And if you leave your jaw alone and let it go where it really wants to go, then it doesn't normally have any problem. But the teeth kind of rule the show, so they make the jaw go backward. Like I have a little bit of a jaw joint problem, and if I relax my mouth and just kind of relax and hold my head in a normal head and shoulder relationship, and just open and close my mouth, my lower front teeth just want to go out here where it's edge to edge. But when I bite together, I go back like that, but it feels a little uncomfortable, but it's not bad. And so many people are that way. So when you make splints or deal with this, try to get the jaw to close where it wants to close, and then make your teeth fit together in this new jaw position, you see. And that's where you take care of it. You let the jaw go where it wants to. Then it doesn't press on the retrodiscal tissue, and we'll have to understand it better. Now, this young lady has a deep bite, and her front teeth are sticking back like this, and she wants them to go forward, and so she's having some irritation with the retrodiscal tissue, and she's got a jaw joint problem. So her parents brought her in, and we'll try to look at it from a different angle here. Now, this is on the right side of the mouth, and you'll notice that the lower front teeth, these teeth down here, and these are the upper front teeth, are way back in here, and the lower ones are fitting up underneath there, and they can't go forward at all. And so the Class 2 Division 2 situation is helping or contributing to the TMJ problem. You could have a lot of Class 2 Division 2 cases, and they may not have any jaw joint problem at all, but here you do. Now, something kicked it off. Maybe she got hit in the jaw back here and jammed it, and the condyle, fitting up in here, and your fossa's kind of like this, and the condyle's back in here. This retrodiscal tissue stays up here, and this is your jaw, see, coming down like that. And this is the condyle, and we're going to be jamming it into this tissue area here. And so you get pain with that, and you take care of this problem, and your TMJ problem goes away. But the thing is, this is the reason for this being irritated. You can't move, she can't get her jaw forward. So you take a person like that, and you find out where their jaw wants to go. And actually, if you let her relax her jaw, her lower front teeth would be set down here, something like this in front, maybe even out here in front of the upper teeth. Out here, since they're going back this way, they'll probably be in front of it. So we're going to have to deal with this and get this out of the way some way or another, so that the jaw can come forward in a normal way. Now, let's go on. Now, on the other side of the mouth, you've got the same picture. This is the jaw needs to come out here. In other words, this molar right here should be fitting kind of like that, and then have the upper tooth coming down in that little groove right there on it. Instead, it's right reverse of that. If I erase that, you can see that this tooth is way back here, and it needs to be up here in this fashion. Now this is a problem with Class 2 cases. In Class 2, and you've got these teeth coming up, the roots of them way on up in here somewhere, and their tooth is bent like this, and the jaw goes up here and hits this, and it can't come forward. Now, there's a tremendous amount of not understanding what is the reason and everything, and not knowing how it can be treated, because normally the dentists going to dental school are not taught enough orthodontics to even know what it is, hardly. So I went to a guy's lecture, one time. I mean, I went 3 times. He lectured on temporomandibular joint problems, and I figured out everything he had was orthodontically caused, and that wasn't the reason. But this guy, a student I had, was in his class once, and said a lady came in with this problem right here. And he immediately deadened these teeth and ground these centrals off and let the jaw come forward, and said that he was there the next day when this lady came in. He did a root canal on them, of course, and all this, and her jaw was free to come out, and she was tickled to death. First time she had had a decent night's sleep in 10 years. And so this is a ridiculous treatment for getting the teeth out of the way here. So if you knew a little orthodontics, you would know that you can move these teeth, pick them up and point them out like this. Most people just, dentists, they're just afraid to teach dentists really some orthodontics that they really need to know how to do, or at least know it's correct to do it that way, and send them somebody else to work on it if they don't want to work on it and don't want to do it themselves. Now, that's what we're going to do to this young lady. This was bothering her. Now, if I put her in a splint, I would have to bring her out way out here, and it'd be such a big gap in here that that would slow us down an awful lot. So I talked to her, if the pain, if she'd give me just a little time, I'll get these teeth out of the way. That was one thing the other guy had. He didn't need any time. He just deadened them and ground them off. But this, now she's going to spend the rest of her life with 2 crowns that stuck on some roots that are left. He did a pulpotomy on them and everything else. But that's a ridiculous way to treat a TMJ problem. Now you can look at the model in here. The tongue isn't going in the right position, really. It's coming out here. And here is the upper lateral, and here are the centrals, the laterals out here, laterals over here, and the centrals are back here. Now these need to be moved forward, both of them, and need to be intruded at the same time. So I'll show you what we did. And if you understand this, somebody can come in like this, and you can put your hand right here and let them open and close in a normal fashion, and you'll see actually if they just close without touching their teeth, their lower teeth would come out to here somewhere like that. Now let's see if I've got any other things here. Now this was back in 1987, and this young lady has a class 2 malloclusion. In other words, the jaw is back one whole notch. So the teeth can be perfectly straight down here with the lower jaw in a class 2 case. But if it's a class 1 and the teeth are in the correct position and you close together, and these teeth will be crowded, it's all get out down here on class 1 case. You might not, excuse me, I've been blocked up here so much this year. Now the upper centrals are hanging way down like this, and they're tilted back. I can't draw that back like that, but that's holding this jaw back. In other words, the jaw cannot come out to the front to take the condyle off of this retrodiscal tissue that is developing the synovial fluid, highly vascular tissue, and if you get it irritated, it swells and it sticks up, and you got this problem to start with. Maybe it's not hurting, but you get the retrodiscal tissue inflamed, and it will bother you. So you can take some anti-inflammatory stuff, sometimes that'll help it, but that's not your problem. All right, here the teeth are back like this again, and this is 12/10 of 87, and you go through this. So I talked to the young lady and I said, we need to put you in a splint, but if you'll give me, if I put the splint in, I'm going to have it, it'd have to come out here, you'd have to open it awful wide to get the teeth there, and you'd fill in, of course, over on the occlusal surface of the teeth in here. But I said, if you'll give me just a little time, I'll move these teeth up here. And we put this rigging in right there. This is a flexible wire we just ran in here and bent down. And it's trying to pick these teeth out. This is an intruding wire, which you'll need to look at a little better to figure out where it's going to go. But this is the distance. This is almost a 1/4 of an inch coming across here. This is about 2/3 of that distance. And we're going to put this stuff in, and it's going to be just a couple of days left in that year. There's the lower teeth. Now they're just sitting there. They go up and bite behind that. All right, here we are, 12/28 of 1987. In other words, it's just by 12/30. I mean, you'll be over in the next year. All right, this arch here is the intruding arch, and it goes way up like this. It has that spring we've shown you how to make. It comes down over on this side over here. And then you take that wire, bend it down here, and I put some elastic chain over the wire and hooked it to these teeth right here. That's a clear elastic chain. Maybe you can see that. Let me erase it. Let's see if I can find what I can erase right up here. All right. Now, see this clear elastic. We hooked on that, it came over the arch wire and came down here. And this wire is being held down like that. And I lectured on this so many times, and I'd show this right here, and it comes right in, you got this omega right in the wire. And everybody would ask me, well, what is the purpose of that omega? Well, I was joking with them. I said, well, it produces a form, kind of a force in there that brings those teeth out like that. And I'll send you a bottle of this tonic, and you can put it on your braces, and they'll all work. You know, of course, I'll just put it in their leg. This doesn't do anything. But I had the wire was too long, and I shortened it right in the middle here. So now we can pull it down here tight to those two teeth. Now get in your head, it's 2 more days till the month is over. I think that they had 30 days in it, in December. And then in two months, and that time we had these teeth out like that. And then that we didn't have to have the splint, but we used it to get the stable position of that jaw. Now let's go on here and see. So here you can see the elastic chain is wrapped around this and coming over this deal. And then we're going to move these teeth up. We're going to intrude them and bring them forward. And let's look at them now. And there it is again. And this is 1228. Now remember this arch wire here is way up here, pulling it down. So it's picking those teeth up. The little flexible wire is just kind of maneuvering them around while you're doing that, which helps out. Now that's another angle of it. All right, here is 315. In other words, we had the month of January, February, and 15 days in March. And those teeth were sitting right out here in this position. And her jaw was free to come forward, and the pain was going away, but I needed to put this splint in to kind of bring this jaw and put it down right where I wanted it put in. But if those teeth had been there and she had not had any pain, she would have never been in there. So we need to correct the overbite. I mean, this overbite and overjet here, this still needs to be open and give that a little bit more room forward. Let's take a look now and see. All right, that's a blurred picture, but those are the same teeth. And there, this arch, you see, was way up here. When I pulled it down here, it pries this tooth up. In other words, to get these teeth to come up like this, you had to put downward pressure on this tooth. And that's 6-year molars are marvelous to do that. That's why you put this little gadget on this and come out here and put in a class 2 elastic, and it'll pull the jaw back on a young person and everything like that, and you'll have very little effect on it. But it did move, it changed this tooth from probably something like this to its back where it opened up this gap right here. But now this person is chewing right in here, and their occlusal chewing helps keep the tooth in line. If we went back and looked at that tooth back over here, let me go back. You see, those teeth did not have that space in there. And so when we put this arch wire in, it comes out here, and it had this deal like this, maybe a couple of strings, and we ran it up high, went around, came down on the other side, and we had a deal like that over there. Now when we pull this down, that's really put in there wrong. If I pull that down, that would loosen this. This needs to be the other way. Let me erase that. You have a tube coming in here, and as the tooth comes out, you drop this and make a loop like that, and now it comes up here, and that pulls down, except your deal would have to be up in this area, and you pull it down, it tightens this up, and that picks this tooth up right there. Sorry for the inconvenience here watching it. Now this is where the class 1 goes back. Now let's get back over here where we were. And that moved those teeth out in 2.5 months. Had it out there. It freed the jaw where the original pain was gone, but we still needed to get this back in here, have this go down some more, and this go up some more. So we put a splint in it to do that. And that's open that space up in there though. Now that's 3/15/88. And here's where this tooth was down here. So it's gone up this far, and it's gone out almost 1/4 inch over there, and it's still got some more to do to get there, which is working fine. That's kind of out of focus. Now here we put the splint in, and let me tell you what a splint is. If you have trouble with the temporomandibular joint back here, and you take and move your jaw forward, and you bite down and it's comfortable, but if you put any pressure out here, it doesn't, this is a gap. There's nothing takes care of it except you've got this fossa back here and the condyle fitting up in here, and you move it forward, then you're taking pressure over there and over on this side right here, and that's the only place you've got pressure. Well, if you do any chewing at all or biting, you're going to really irritate. This is irritated to start with, so you can't do that. So you've got to fill this in right in here, so that when they bite together now, the force goes right up with the bone structure, and you take the force off of this jaw joints where it's sore and inflamed, and give it a chance to heal up, and you move the jaw forward so the condyle is not irritating the retrodiscal tissue. And that's the basis of splints, at least the vast majority of them, is just putting something in here, so when you bring your jaw out here, you bite down, you've got something taking care of the force, where if you just bite up with nothing there, then you've got the force on your condyles and the fossa, and it's on the front teeth up here. So that's what the problem is, and so you know now what to do, so you don't get any problem with that. All right, here's how far that tooth moved in 2.5 months, and put it out to that. And now we put the splint in, and we brought it out further, and we have this fitting in together right here, and we continue with this. And this beautiful young lady decided to get married, and her mother just had a fit. She didn't want her to marry, and she finally, she won out, and she moved to Sarasota, Florida. And I had a student of mine who was real good and knew what he was doing, and I sent her to him to finish up, but we had pretty well had her where she needed to be, and that is the way this case actually ended up. So, and I'm sure that he did a good job. He got the second molars in and all that taken care of, and this was where the splint bit down, but this is where the pressure goes, and it keeps it off of the condyle back in that fashion. And let's see, I think right here, that's where we In the last treatment that I had, I put an intruding wire that was coming out here, and we're bringing these lower teeth down, something like that, which we did that after we put the splint in. You exactly where we're going to go with the teeth. Let's see if somewhere she gets up and moves away. So there's an intruding wire on the bottom, and the top is lined up like that. If you remove this tooth, it was back here somewhere. And then you see those little facets where the lower teeth bit into these teeth up here. And this is making it a little easier. So here is the young lady, and that was the last we saw of her, but she must have got along fine. So she moved to Sarasota, Florida, and married, and as far as I know, she lived happily ever after. So I will say goodbye, and hope that we covered something here that'll help you in dealing with any body that's got a temporomandibular joint. Go immediately, put your finger on the joint and have it open and close real slow, and run your finger around the condyle. And if it's not sore at all, there's something else wrong here, see? But you go to touch it and you'll find a sore spot in it, and then you've got to get off that pressure point and move the jaw forward to get out of that trouble. So I'm going to hang up, and we'll say goodbye, and I'll hope to see you again.